Welcome to our video on neurofibromatosis type 1, 2, and tuberous sclerosis. Let's begin. In this lecture, we'll discuss neurofibromatosis type 1, neurofibromatosis type 2, and tuberous sclerosis. For each condition, we'll discuss genetics, clinical presentation, diagnosis, and management. Let's start with neurofibromatosis type 1. Neurofibromatosis type 1 is also known as von Recklinghausen disease. It is an autosomal dominant condition with 100% penetrance. In other words, all people carrying a mutation will have clinical manifestations characteristic of neurofibromatosis type 1. This condition is caused by a mutation in NF1 gene on chromosome 17. NF1 gene codes for neurofibromin, which normally inhibits RAS protein. The normal function of RAS protein is stimulation of cell proliferation. Therefore, a loss-of-function mutation of the NF1 gene results in disinhibited RAS protein and unregulated cell proliferation. Clinical features of neurofibromatosis type 1 can be remembered by the mnemonic Cyclops. Patients with this condition commonly have hyperpigmented macules or patches known as café au lait spots. Neurofibromatosis type 1 can also be associated with intellectual disability. Patients may also have cutaneous neurofibromas, which are tumors of peripheral nerves. This is where the name of the disease comes from. Ophthalmologic exam of these patients may reveal Lisch nodules, which are pigmented brown-colored iris hamartomas. Please note that Lisch nodules seen in neurofibromatosis type 1 and brush-field spots seen in Down syndrome patients are different from one another. Brush-field spots are white spots on the iris of Down syndrome patients. Patients with neurofibromatosis type 1 may also present with optic gliomas, which are tumors of the optic nerve. Pheochromocytoma, a catecholamine-secreting tumor, is another potential finding. Neurofibromatosis type 1 can also be characterized by seizures and focal neurological signs, most commonly due to a concomitant meningioma. Here we see café au lait spots in a patient with neurofibromatosis type 1. One can appreciate these hyperpigmented light brown patches on the skin. This is an image showing cutaneous neurofibromas. They can be described as flesh-colored, raised papules, typically found on the trunk. Remember that cutaneous neurofibromas are the tumors of peripheral nerves. Here, one can see a comparison of Lisch nodules and brush-field spots. Again, Lisch nodules are brown-colored hamartomas on the iris, characteristic for neurofibromatosis type 1, while brush-field spots are white spots on the iris, characteristic for Down syndrome. This is an axial MRI image showing an optic glioma on the optic nerve, which is another type of tumor associated with neurofibromatosis type 1. Let's briefly review the diagnosis of neurofibromatosis type 1. Diagnosis is based on a combination of the symptoms and clinical findings that we discussed on the previous slide, and genetic testing for NF1 mutation. Management of neurofibromatosis type 1 includes surgical excision of associated tumors, namely the neurofibromas, optic gliomas, meningiomas, and pheochromocytomas. Otherwise, symptomatic treatment for any other clinical feature is recommended. A 15-year-old boy is brought to the physician by his mother due to 3 seizures over the last 2 weeks. His past medical history includes surgery for a left optic glioma. On physical exam, he has multiple skin-colored plaques on his back and slightly hyperpigmented patches diffusely on the skin. Fundoscopic exam reveals brown nodules bilaterally on the iris. What is the most likely genetic abnormality responsible for this patient's condition? This patient presents with 3 episodes of seizures. He also has a past medical history of an optic glioma. Multiple skin-colored plaques on his back are most likely neurofibromas, while slightly hyperpigmented patches are café au lait spots. Brown nodules bilaterally on the iris suggest Lisch nodules. All these findings are consistent with the diagnosis of neurofibromatosis type 1. The genetic abnormality responsible for neurofibromatosis type 1 is a loss-of-function mutation in NF1 gene on chromosome 17. Therefore, the product of NF1 gene, neurofibromin, can no longer inhibit the RAS protein, which stimulates unregulated cellular proliferation. Now we'll move on to neurofibromatosis type 2. Here is a sequence of topics we'll follow while describing this condition. Neurofibromatosis type 2 is an autosomal dominant condition. It is caused by a loss-of-function mutation in NF2 gene on chromosome 22. NF2 gene normally codes for Merlin or schwannomin tumor suppressor protein. The loss-of-function mutation in neurofibromatosis type 2 inhibits tumor suppression, and the patients develop multiple tumors. The clinical presentation of neurofibromatosis type 2 includes bilateral vestibular schwannomas, which are also known as acoustic neuromas. These are tumors of Schwann cells associated with the vestibulocochlear nerves. They are found within the cerebellopontine angle and may cause sensorineural hearing loss. Patients with neurofibromatosis type 2 may also present with juvenile cataracts. Finally, central nervous system tumors such as meningiomas and ependymoma are also common in these patients. Here we see an MRI image of bilateral acoustic neuromas. Please note the tumors in both cerebellopontine angles. We can also see a parasagittal meningioma with a dural tail in this patient. This is the eye of a patient with cataracts. One can appreciate opacification of the lens. Remember that neurofibromatosis type 2 is associated with juvenile cataract. Let's briefly review the diagnosis of neurofibromatosis type 2. Diagnosis is based on a combination of the symptoms and clinical findings that we discussed on the previous slides and genetic testing for the NF2 mutation. Let's talk about the management of neurofibromatosis type 2. For the acoustic neuromas and meningiomas, treatment is generally surgical excision. Other tumors can be treated with radiation. Finally, one can perform lens replacement surgery for cataracts. A 6-year-old girl is brought to the physician's office by her father due to problems at school. Her teachers report that the patient never listens to them. Her past medical history is significant for bilateral lens replacement surgery due to infantile cataracts. Audiometry reveals bilateral sensorineural hearing loss. MRI of the brain reveals bilateral masses at the cerebellopontine angles. Which central nervous system tumor is this patient most at risk for? This patient is initially evaluated due to inattentiveness at school. However, audiometry reveals bilateral sensorineural hearing loss that may be the cause of her behavior at school. MRI of the brain reveals bilateral masses at the cerebellopontine angles. This finding is consistent with bilateral vestibular schwannomas. This patient also has a past medical history of infantile cataracts. Considering all these findings, this patient likely has neurofibromatosis type 2. Two central nervous system tumors that this patient is at risk for developing are meningioma and ependymoma. Lastly, let's talk about tuberous sclerosis. We'll review genetics, clinical presentation, diagnosis, and management of tuberous sclerosis. Tuberous sclerosis is an autosomal dominant condition with variable expressivity. In other words, the severity of this condition differs from one patient to another. Please keep in mind that tuberous sclerosis may also be caused by de novo mutation. There are two genetic mutations that can lead to tuberous sclerosis. Tuberous sclerosis can be caused by a mutation in tumor suppressor gene, TSC1, on chromosome 9. This gene codes for hamartin protein. This disease can also be caused by a mutation in tumor suppressor gene, TSC2, on chromosome 16. This gene, on the other hand, codes for tuberin protein. Clinical features of tuberous sclerosis can be remembered by the mnemonic hamartomas. These patients commonly have central nervous system and skin hamartomas. Let's recall that a hamartoma is a disorganized tissue proliferation in its original location. Tuberous sclerosis is also accompanied by angiofibromas, which are usually on face. These angiofibromas are also known as adenoma sebaceum, but they do not represent sebaceous gland tumors. Instead, they are benign vascular tumors. Patients with tuberous sclerosis also have some degree of intellectual disability. Ash leaf spots are hypopigmented macules or patches seen on the patient's trunks. Cardiac rhabdomyoma, on the other hand, is a tumor of the myocardium commonly seen in tuberous sclerosis. These patients may also have renal angiolipomas, which are tumors consisting of blood vessels, smooth muscle, and adipocytes. CNS hamartomas can result in seizures. Finally, patients might also have a shagreen patch, which presents as a large plaque that is usually on the lower back with rough skin texture. Tuberous sclerosis is also characterized by an increased incidence of subependymal giant cell astrocytoma and ungual fibromas. Subependymal giant cell astrocytoma, as the name implies, is a tumor of astrocytes immediately under ependymal cells. Ungual fibromas, on the other hand, are benign connective tissue growths around the nail bed. Here we see a patient with facial angiofibromas, a finding that is seen in tuberous sclerosis. It is a papular rash with small plaques in a butterfly distribution across the face. This is the classic appearance of an ash leaf spot. Please take a close look at this hypopigmented patch on this patient's skin. Here, one can see an echocardiographic image showing a cardiac rhabdomyoma. One can appreciate these masses in myocardium. This is the classic appearance of bilateral renal angiolipomas in a patient with tuberous sclerosis. These patients present as hypodense circular lesions in the renal parenchyma. Here we have an image of ungual fibroma. One can see this benign connective tissue growth next to the toenail. Let's briefly review the diagnosis of tuberous sclerosis. Diagnosis is based on a combination of the symptoms and clinical findings that we discussed on the previous slides, and genetic testing for TSC1 and TSC2 mutations. Tuberous sclerosis has unique management that is great fodder for step 2 questions. These patients must get regular skin and eye exams to monitor for tumors. Because of the risk of renal angiolipoma and intracranial tumors, these patients must get serial MRIs of the kidney and brain respectively. Because of the risk for cognitive impairment, these patients require neuropsychiatric screening. Finally, these patients also require baseline EEG due to the risk of seizures. The patients are commonly prescribed anti-epileptics to control the seizures. Here we have a table summarizing all the neurocutaneous syndromes and their high-yield features. Pause the video and take a moment to consider this table. A 7-year-old boy is brought to the physician for a routine well-child visit. He was diagnosed with intellectual disability at the age of 3 years. He was incidentally found to have bilateral renal masses 2 years ago. The physical exam reveals skin-colored nodules around the fingernails, several hypopigmented patches on the trunk, and one large hyperpigmented plaque on his lower back. Echocardiography reveals a mass in the left ventricular myocardium obstructing the outflow tract. What is the most likely cause of this patient's echocardiographic findings? This patient was found to have bilateral renal masses, suggesting renal angiolipomas. Skin-colored nodules around the fingernails are consistent with ungual fibromas. Hypopigmented patches indicate ash leaf spots, while one large hyperpigmented plaque on the lower back suggests a shagreen patch. All these findings indicate tuberous sclerosis. Echocardiography reveals a mass in the left ventricular myocardium obstructing the outflow tract. A myocardial mass in a patient with tuberous sclerosis is most likely a cardiac rhabdomyoma. And that concludes this section.